panel, we're ready to get started. Welcome back to our educational video. My name is Susan Peck. I am a nurse practitioner in the Division of Gastroenterology, Hepatology, and Nutrition at the Children's Hospital of Philadelphia. This episode is on surgery and hospitalization. I would like for you to meet our panel.
I'm Natalie Walker, pediatric nurse practitioner in pediatric surgery.
Bob Baldessano, Director, Center for Pediatric Inflammatory Bowel Disease.
I'm Linda DeSantis. I'm the nurse manager for the inpatient GI unit.
I'm Peter Mattei, pediatric surgeon.
I'm Noelle Bates. I'm the inpatient nurse practitioner for the Division of GI and Nutrition.
Thank you very much, and we're happy to have you with us today. Dr. Baldessano, since this episode is on surgery, when patients have inflammatory bowel disease, when is surgery indicated?
Well, with people who have inflammatory bowel disease, again, we all know there's different types of inflammatory bowel disease, and because of that, there's different therapies. And so we typically like to try to use medical therapies, but often surgical therapies are very important for us to take care of our patients. And so patients who have Crohn's disease, they often may require surgeries for if they have a lot of scarring or narrowing within their intestinal tract, if they develop abscesses, or if they develop a problem called perirectal disease. This is when you have abscess or infections around your rectum. And when this happens, that really is a medical surgical problem, and it's really very important that the medical team and the surgical team works together to really give the best care. With ulcerative colitis, again, surgery often is an important therapy for some people, and I think Dr. Mattei will be talking about this, about having sometimes to remove the part of the intestinal tract that is irritated or inflamed to improve quality of life and to treat our patients.
So Dr. Mattei, what types of surgeries are available for patients with inflammatory bowel disease? Do families have different options?
Yes, and of course it does depend also on the type of disease, the type of inflammatory bowel disease that we're dealing with. In general, surgery involves removing that portion of the intestine that is the culprit that is causing the problem. Surgery is not a cure for either of the diseases, but we can help patients get over a particularly difficult complication or difficult time in their disease. So for ulcerative colitis, we would remove the colon and the rectum, which are the organs that are involved with ulcerative colitis. And in Crohn's disease, because it can affect multiple different parts of the bowel, we would remove that part of the bowel that's most involved.
Can patients with inflammatory bowel disease have laparoscopic surgery?
Most patients who need surgery for inflammatory bowel disease are candidates for minimally invasive surgery or laparoscopy. And with laparoscopic surgery, we can use much smaller incisions, and the patients generally recover more quickly and have less pain after surgery.
When I hear surgeons talking about operations, they sometimes use the word resection. What does that mean? Resection
is exactly the removal of the offending part of the intestine that is causing the problem. Not every patient needs a resection. In some cases, if there's a narrow stricture or narrowing of the bowel, then we can do what we call a stricturoplasty, which involves preserving the bowel, because after a while, if you remove too much of the bowel, you can end up with short bowel or not enough bowel to digest the food and absorb the nutrients that you need. And so in that case, if we need to preserve the length of the bowel, we can do a stricturoplasty, which is a way of opening up that narrow spot.
You mentioned laparoscopic, so you're saying you use scopes. How exactly is that different than regular surgery?
That's right. Well, with traditional surgery, we would make generally a rather large incision, because in order to, even though we're removing a small segment of the intestine, we tend to need a large incision in order to mobilize part of the intestine that we need to remove. But nowadays with laparoscopy, and mostly what we're talking about are laparoscopic assisted operations, where part of the operation is done laparoscopically. And what that means is that we use tiny incisions, typically 1/2 inch to 3/4 of an inch in size, one of which is for a telescope or laparoscope in which we can see what we're doing. And then through the other small incisions, we can use various instruments to mobilize the bowel, divide adhesions, and put us in a situation where we can actually use a very small incision to bring the bowel up out of the abdomen and resect it or remove it.
So you mentioned one of the advantages is scars are smaller. Are there any other advantages of laparoscopic?
We do see that patients recover more quickly after laparoscopic surgery. They have less pain, and they're able to resume their activities both in the short term even just walking in the hallways after the surgery, but also resuming their usual activities such as going back to school or work and sports and things like that. I think the greatest appeal to most patients and their families is the scarring, but for us we also see other advantages, including the more rapid return to functional activities.
And for laparoscopic surgery, is that done everywhere? Do all surgeons nowadays do it that way, or is it a specialty that a surgeon develops?
It's becoming more and more common everywhere, but I don't think it's available everywhere yet, especially in inflammatory bowel disease. But in specialized centers, we're using it much more frequently. In fact, it's rare to have for a patient to undergo a very large incision and large operation anymore.
And when would a patient not be a candidate for laparoscopic surgery?
That's rare in our population, in children, but patients who've had multiple operations where they would have very many adhesions, lots of scar tissue, that can make it very difficult to do a laparoscopic operation because then it's not safe sometimes to manipulate the bowel under those circumstances.
Dr. Baldessano mentioned perirectal or perianal disease. Are there special operations involved in taking care of that type of inflammatory bowel disease?
Yes, there are. In fact, most patients with, and this applies mostly to patients with Crohn's disease. Perianal disease is very uncommon in patients with ulcerative colitis. But with Crohn's disease, there is a subset of, there are patients who have perirectal issues, including abscesses, fistulas, and fissures. And most of those patients will at some point require an examination under anesthesia, in which we can examine the patient very carefully in a painless way and determine the extent of their disease. And then we can treat acute problems such as abscesses, which typically involve an incision and drainage of the abscess, sometimes placement of a temporary drain, which is a silicone rubber tube that drains the material for a certain amount of time to allow healing. And then there are fistulas, in which case we would apply a aceton or a silk thread that would keep the fistula under control and prevent infectious complications.
And this has really resulted in much better outcomes. Probably 5 or 10 years ago, there was a tendency that the medical people didn't include the surgical people in this particular approach. It really wasn't the team approach that we have now. And doing this team approach really has made the outcomes of this particular problem just much better.
I know that many patients worry about having to have a bag on their abdomen or belly when you're talking about surgery. When is an ostomy necessary, and what exactly is an ostomy? I'll turn that over to Dr. Mattei and Natalie.
Well, ostomies luckily are very rarely required these days. It used to be much more common before all of the wonderful and improved medications that we have now. But generally we use ostomies to divert the stool from the area of involvement, either another part of the intestine or the perianal area. But again, I want to stress the fact that these are very rarely done these days, and only for very extreme complications or very difficult to control disease.
And an ostomy, by definition, is an operation where we make an opening in the skin and pull up a portion of the intestine, and that is where the child would go to the bathroom, into the bag.
I see that we have an audience question.
What do I have to do to take care of it? Can I go to school? Can I swim and play sports with an ostomy?
You can do all of the above. And so to take care of your ostomy, you use a pouch and a flange that goes onto your abdomen around the ostomy, and that collects stool. You're able to go to school and live your daily life, including sports and swimming, all with an ostomy.
What does an ostomy look like, and will I have it forever?
In most cases, the ostomies are temporary, and an ostomy is in your right lower portion of your abdomen, and it's red and moist, and it has stool coming out of it into the pouch.
And the pouch is a bag.
Is a bag.
Can you make those bags attractive?
And we do the absolute best that we can, and I think we've all learned over time sort of tricks of the trade to make ostomies as much of a low-profile device. So under clothes, they're very hard to detect. In fact, this summer at our IBD camp, we had a few children who had ostomies, and they were in the pool swimming with everyone else. And a few children who knew they were going to go into surgery in the fall were very curious to find out who those children were, because you can't pick them out in the crowd, and that's the very nice thing.
Hospitalization. Does everyone who have IBD go into the hospital?
Certainly not. So Since I'm an inpatient nurse practitioner, I mostly see children who are diagnosed with their inflammatory bowel disease as inpatients. The very nice thing for me is that I can tell them just because you were diagnosed as an inpatient and you were very sick at the time of diagnosis doesn't mean that every single time you have a flare of your disease, you'll have to come back in. Likewise, the great majority of our patients are diagnosed as outpatients and they remain outpatients. So when they are feeling ill, when they do have a flare of their disease, they work more through the telephone system, sometimes having a sick visit with their pediatrician or primary care nurse practitioner, sometimes in communication with their outpatient GI team to manage their disease outpatient. So certainly not everyone has to come in. But if you do have to come in and you do have to be hospitalized, we're prepared and we can help you make that transition.
Dr. Baldessano, when would somebody have to come into the hospital?
Right, well, the exciting thing is with new therapies that we have available now, hospitalization is much less frequent. 10 years ago or 15 years ago, visiting a hospital or staying in the hospital if you had inflammatory bowel disease was not uncommon. Now it's very uncommon. I mean, last year at our institution, we saw 1,600 kids with inflammatory bowel disease. Maybe we have 2 or 3 in the hospital at any one time, to give you an idea that most people never actually get admitted into the hospital, even for diagnosis or for therapy. But times that we need to have people come into the hospital is if the symptoms are such that they need to be corrected quickly. You can make people better faster if they come into the hospital than often to try to do this as an outpatient. For certain concerns that we're afraid maybe surgery is necessary, we'd want these patients to come in to watch them closely, because if you do need to get surgery, we can get it done a lot quicker if you're already in the hospital. So in certain instances, hospitalization is really very necessary. But in most cases, fortunately, it's something nowadays that we just don't need to. I don't consider that part of the care of an IBD patient to say, oh, you're going to spend time in the hospital. 20 years ago, I think most physicians would have said, you're going to spend time in the hospital. And lucky nowadays, we don't seem to have to do that with our new therapies and our new approaches.
So we have another audience question.
What is the hospital like if I have to go?
That's a great question. Linda, can you address that?
The inpatient GI unit is a 24-bed unit. It's all single room, so every patient has their own private room and bathroom in their own room. There's a setup there so that parents can stay overnight. We have lots of additional activities and diversionary things for patients who are in the hospital for a while. We have some child life therapists, we have teen activities, we have a music room. We also have an educational center on the inpatient unit, where the nurses that are experts in the care of children with IBD staff that area and help with educational teaching for the entire family while they're there, be it an ostomy or any other additional care that they may need, and educational stuff to go home with. Our whole goal is to work with the whole team and transition these patients through their recovery and to their normal daily activities at home.
It's really the philosophy now different than, again, 20 years ago, is when you were hospitalized, you were in your bed, and if you got out of your bed, you'd get in trouble. Nowadays, it seems like we really try to get kids up and doing things, doing your homework and having whatever activities that you're able to do, and to try not to make it so that you're stuck in your bed the whole time.
Right, there's plenty of activities, and the nurses get patients' families involved in every aspect of their care, including those types of activities while they're in the hospital, so that we can get them home quickly.
What is the expertise of the nursing staff? Do they know about inflammatory bowel disease?
Oh, absolutely. All of our nurses go through extensive training to learn about the ins and outs of every single GI disorder, not just inflammatory bowel disease, but they are considered the experts in the hospital.
So who will meet the family when they come into the hospital? Who is the team?
As outpatients, families are very used to having 2 people at most that they converse with and see during clinical visits. Their attending physician and either a fellow physician or a nurse practitioner. When they become inpatient, we have a vastly huge inpatient team that's dedicated to caring for your child. You may or may not see those people you've come to know and have built a rapport with as an outpatient, but that doesn't mean we aren't communicating all the time. And our team is rather large. We have an attending physician, a fellow physician, myself, I'm always on service in the hospital, but we also have a GI social worker, we have nutritionists, dietitians, we have psychologists, psychiatrists, child life therapists. It's a very huge team. We also, being a teaching hospital, have resident physicians who are learning how to become pediatricians, who are doctors, but are learning how to become pediatricians and are rotating on a GI service to learn more about GI specifically. We are a bit of an intimidating group, but we try to keep our sizes down when we come into your room. But at some point, you'll be meeting very many of us.
Dr. Baldessano, if say Dr. Mattei needs to be consulted, how does that work? How do other services get involved in the care of children?
Okay. Well, when a child's admitted into the hospital and admitted to the GI service, typically it would be the GI attending along with the team that would decide on, do we need to consult or do we need to get the expertise of some of the other people in the hospital? And with inflammatory bowel disease, the most common is surgery. And so if once we evaluated the patient and if we felt that we needed a surgical input, then what we would do is call up surgery, put in what we call a surgical consult. The surgeons would come by and do their evaluation. Before we would do that, though, we would always speak to the patient and their family so that they're expecting and they know who's going to be walking in and the type of questions that'll probably be asked of them. Then once the surgeons or whatever consult service we've asked to come for help, after they evaluated the situation, once again we get together as a team and decide on what's the best care for the patient.
So what would they expect if they were to meet you, Dr. Mattei? What would happen?
Well, typically one of my residents or fellows from the surgery team would come by to introduce themselves and to talk to the family, mostly for data gathering. And then at some point I would come in and talk to the family, and we try to use a very gentle approach. You know, we don't like the stereotype of the surgeon who kind of comes in and takes charge. I mean, we're there to try to help and to provide a service. We try to involve the families and the patient as well in the decision-making process, so that you know, I'm fond of saying that we make the recommendations, but the families and the patient actually make the decisions. And we try to talk very generically about surgery in general, and so that they know what to expect, because I think that takes a lot of the fear out of the whole process.
And Natalie, when would a family meet you?
Well, if Dr. Mattei or the surgeon feels an ostomy is indicated, they would either meet myself or one of my partners, and we would go up and introduce ourselves. We would take a look at the child's abdomen. Everybody's body is different. We know we want to shoot for the right lower quadrant, but we look at the shape of the abdomen, what type of clothing, where the child would think that the ostomy is easy for self-care, and take a look at that. And then we would preoperatively mark the site of best location for the ostomy.
So Dr. Mattei, how do you determine what type of surgery each individual patient needs?
Well, it really depends a lot on the pattern of the disease. For example, in Crohn's disease, we would address the particular location of the bowel that's involved. In ulcerative colitis, it's a little more standardized because the operation involves removal of the colon and the rectum. And the operation for ulcerative colitis is also conducted in 3 parts. The first part is removal of the colon, and that's the part that can usually be done laparoscopically with a great deal of benefit to the patient. The second part is the reconstruction of the rectum using a part of the small intestine, and that's commonly referred to as a J-pouch procedure. And then the third portion is the ileostomy, and patients do need an ostomy temporarily for this operation until the newly formed rectum has healed. And so that can be, sometimes all 3 parts can be done in one stage. More often it's done in 2 stages, where the second stage is actually closure of the ostomy. Or in rare cases, for example, in emergency situations, we would do it in 3, we would do each of those 3 parts separately, and that's called a 3-stage operation.
Dr. Mattei, if you do decide to do the 3-stage procedure for ulcerative colitis and you do need to have an ostomy, you had mentioned that it was a temporary ostomy, what's the definition of temporary? Is that a day, a week, a month?
That's a good point. Typically, it's on the order of 2 to 3 months. So we would try to do the operation, for example, at the beginning of the summer and close it before school starts again in September. That's a typical example of the timing.
And for kids who do have this, I guess they call it the ileoanal pull-through procedure for people who have ulcerative colitis. And typically, as a medical physician, I would consider surgery when a person is not responding to the medicines. What's the quality of life like after you have this ileoanal pull-through procedure? Can kids expect to be regular kids?
Generally, it's quite good. Our goal is to have patients have a normal lifestyle afterwards, where they can go to school, they can go to work, they can play, they can do everything that everyone else does. The pattern of bowel movements is not quite what some might consider normal, but it is usually very acceptable. Typically 2 to 3 bowel movements per day, maybe sometimes 1 at night, and with good control, and that's also an important part of it.
So the job of the large intestine, that portion of the intestinal tract that you're removing, really, my understanding is it helps absorb water. So as long as you drink enough, and again, it might be one of the reasons why the bowel movements aren't as formed is because you're taking that sort of organ out that sort of absorbs water, but it does sound like most people have a pretty good quality of life afterwards.
That's true. We tend to consider the colon as an organ of convenience and not a true vital organ, and so that we can get by without one. But there may be some slight modifications, for example, drinking more water, that some people have to accommodate. But in general, the lifestyle is quite good, and that's always our ultimate goal.
I mean, some of the advantages of the surgery, again, this is individual. You know, each patient you have to look at and say what's best for them. But the advantages that the surgery I guess affords a patient is it takes away the risk of colon cancer, and it also can give you the opportunity to get off many of the different medical therapies that most of these children are on at the time when we suggest or talk about surgery.
And several of the children that I see are the sickest of our sick children, and they've been sick for so long that it's hard for them to remember a time where they truly felt well. And that's the most important benefit to those children who have an ostomy, that it returns them to a state of normal life that they remember before they get sick.
So Linda, Noelle mentioned that the nursing staff is excellent at teaching families how to care for their disease and surgical interventions. What else can families expect from the nursing staff when they're an inpatient?
The nursing staff in the inpatient unit really serves as a conduit or a liaison between a lot of the other services that we involve. We have psychology services, behavioral health services. Again, there's child life services that are involved. Anything the patient family really would need, the nurse can serve as that liaison and get in contact with those services for the family.
And they're the people that are available to the family 24 hours a day?
24 hours a day. We also have some nursing assistants that are on the unit and nurse techs that they'll also be involved in the care of those patients as well.
And what type of experience does the nursing staff have? Are they pediatric experts or?
They're pediatric experts in the care of patients with IBD. They've received extensive training. Some of that training is done actually by other members of the team at different portions throughout the year. They have spent time in some of the other departments, such as the GI suite where some procedures and things are done. And they also are the people that will help to educate the family as well.
So are there any other words of wisdom we would like to share with families about surgery and hospitalization?
Well, it's scary to hear you have to come into the hospital. But I think most people would say once they get into the hospital and they get to meet everybody on the floor and that we're all really working together as a team, that you make actually a lot of friends. It's not that you look forward to go to the hospital, but most people when they leave they feel so much better. And many of the families that we're saying maybe you need to come into the hospital to get things better, and at first are a little bit resistant. After they've been in the hospital, people are happy that they went in, and even sometimes wish they would have gone in a little bit sooner so they could get better faster.
Thank you, panel, for participating in today's episode. This was a very interesting and enlightening discussion on hospitalization and surgery. And thank you to all of you for joining us today for our educational video. Once again, if you have questions that were not addressed during the session, please direct them to your healthcare provider. There are additional resources available to you at the end of this DVD. Thank you again for joining us for this educational program.